I wasn't sure if I was still muted or not. Okay. So yeah, thank you, Dr. Hassan, for the introduction there. So my name is Dr. Gazi, and I'll be just talking about the role of opiates in the management of acute and chronic pain in the dental practice. All right, so let's see. So just to start with just an introduction here, the use of analgesics to manage patients' pain is pretty important and is a pretty important aspect of dentistry. The patient's health status plays a key role in prescribing drugs to manage the pain. Clinical conditions of the patient can be obtained by taking a thorough medical history, as well as clinical examinations to determine the type of drug to prescribe. There must be a logical connection between the two. Opiates are commonly prescribed by dentists for dental pain management, but in most instances, the pain can be effectively managed by non-opiates, as we know, such as acetaminophen or NSAIDs. Opiates are also commonly subject to abuse, as Dr. Hassan was just alluding to, and it results in harm to the patient. Thus, the dental practitioner must reasonably use reasonable professional judgment before prescribing these class of drugs. If there are no reasonable alternatives, usually that's when, and the risks and benefits are weighed before prescribing these drugs, then prescribing the opiates are deemed necessary usually. And if the dentist decides to prescribe opiates, they must place a reasonable limit on the prescription, meaning not to overprescribe the number of tablets. And collaboration with other healthcare professionals it usually should be considered. For example, asking the pharmacist if they have a history of opiates and whatnot. So yeah, that's just a brief overview of what we'll be talking about today. So if we dive into some of the specifics here, we'll start by talking about the management of acute pain. So for acute pain, the dentist should focus on interventions to solve the underlying source of the pain first, as soon as possible. So for example, caries removal, pulpectomies, incision and drainage. With most of these procedures, after the source of the pain is treated, postoperative pain becomes a likely factor for approximately 2 to 3 days. Oh, sorry, I forgot to switch to the next slide. Oh, there we go. Yeah, so as I was saying, for approximately 2 to 3 days, postoperative pain is usually something we have to manage, and analgesics may be prescribed to manage the patient's pain for these days, as the pain will diminish after this period. Before prescribing the drugs for post-op pain, some of these things should be considered. Is the prescribed drug safe for the patient? Does the drug have any potential risks? Is the source of the pain eliminated? The use of analgesics should be individualized to the patient's medical history, the level of post-op pain anticipated. For example, if the patient had a surgical extraction with bone removal versus say like a patient that just had an atraumatic simple extraction that you just popped out. NSAIDs and acetaminophen should be maximized before adding any opiates usually. And a pre-op or a loading dose of NSAIDs may be beneficial at times. A couple more things here. So dose and frequency of analgesics should be optimized before switching to other analgesics. Avoid prescribing long-term use of analgesics. So they have, it's very easy for a lot of patients to get addicted to them, especially if they have a history of it. For children, when we're prescribing, we need to calculate the dose by their weight. For elderly, usually it's best to avoid using high doses of analgesics. And I'll be alluding to some of what I'm saying now in the next few slides, but again, just as a summary, for mild to moderate pain, it's usually best to start with acetaminophen. For all moderate to severe pain, NSAIDs are pretty sufficient. And Currently, the evidence-based dentistry suggests that the concurrent or alternative use of acetaminophen with NSAIDs may be beneficial for moderate to severe pain. So there's a lot of research that states that if you take an NSAID and an acetaminophen together at the same time, it works pretty well with their mechanism of actions. So basically from all of this, the big takeaway would be only a minority of situations should require opiates. As like I said, a lot of the research shows that NSAIDs and acetaminophen should be sufficient. So yeah, with the summary that I just said, this is basically a little flow chart that you could follow through. So I'll try to explain some of this in more detail. So we could start with mild to moderate pain. So first, we have to consider acetaminophen for any post-op pain we're trying to treat. For adults, as we probably all know, but just as a refresher, 500 milligrams to 1,000 milligrams every 4 to 6 hours with an allowance of a maximum 4,000 milligrams a day. For children, it's usually 10 to 15 milligrams per kilogram body weight every 4 hours with a maximum of 65 milligrams per kilograms per day. And then if we move on to moderate to severe pain, if acetaminophen is not sufficient for the analgesia according to your clinical judgment, consider NSAIDs. So again, 400 milligrams of ibuprofen every 4 to 6 hours, PRN. You can also, a lot of people I know use naproxen as well, which is also sufficient. One thing to remember is if NSAIDs are contraindicated, so if they have an allergy, if the patient has an allergy or they have a history of gastric bleeding issues or they have severe asthma, NSAIDs would be contraindicated. So in that case, to the acetaminophen, you could add 15 to 30 milligrams of codeine for every 4 to 6 hours PRN pain. And lastly, if they are in severe pain, I think one of the things you can do is doing a local anesthetic block and also prescribing a higher dose of ibuprofen, so 600 milligram of ibuprofen. And if the pain is still very severe, then you can also contemplate instead of doing 15 to 30 milligrams of codeine, you could add 30 to 60 milligrams of codeine to the acetaminophen, or also you could also do 5 to 10 milligrams of oxycodone every 4 to 6 hours PRN pain. So I'm sure we all knew that, but it's just a nice refresher here. So let me just see. Okay, so before prescribing the opiates, there's some things that we need to consider. So now that we know which analgesics are appropriate for certain situations, we need to consider if the patient's pain is well documented and it actually makes clinical sense. So if the patient just comes in and they're complaining of throbbing intense pain, but you're clinically not seeing anything, it should start ringing some bells. Also, is the patient currently taking opiates? Does the patient have a history of substance abuse and misuse? Like I said before, evidence-based research shows that NSAIDs have a high efficacy to resolve pain. Thus, the benefits of prescribing opiates, does the benefits outweigh the risks? That's something you also have to contemplate. Alrighty, so now let's picture that we have a patient that comes in, you're trying to control the post-op pain, and you've determined that opiates are appropriate to use. So we have to usually try and limit the number of tablets of opiates as per the guidelines from the RCDSO. So for a Tylenol 2, it's recommended that we do a maximum of 36 tablets, Tylenol 3, maximum of 24 tablets, and for Percocets, usually 24 tablets. If your clinical judgment concludes that the patient requires more tablets of opiates, it should be deemed an exceptional case and not a common practice. Such situations need to be well documented in terms of your reasoning to exceed the recommendations that I listed here. Alrighty, so the patient came in the first time, you gave them the prescription of opiates, and they come back in a few days and now they're complaining of pain again. So what do? So the very first thing is you have to reassess your initial diagnosis and make sure that you're really accurate on assessing the source of the patient's pain. Like I mentioned before, that should be the first line of the treatment. So if you initially thought it was 4-6, but now you see that some of your radiographic evidence actually may suggest it's 4-7, that's something that might be worth looking into. The second thing is consider non-pharmacologic management of pain. So again, like I said, incision and drainage, extractions, pulpectomies, pulpotomies, so on and so forth. Next, you could consider prescribing a maximum dosage of NSAIDs or acetaminophen and discontinuing the opiates. And as a last resort, in that same appointment, depending on your clinical judgment, you can increase the dosage of the opiates in a second prescription. Alrighty, so the patient's gone. Now this patient comes back for the third time. Hey doc, I'm in severe pain. I can't bear with it. What do I do? And at this point, you're trumped. You don't know what to do because initially you're confused, and now, just like this child in the picture, you're even more confused. And so again, the protocol would be what we said in the last slide, which was reassessing diagnosis, non-pharmacologic management, discontinuation of the opiates, adding NSAIDs and acetaminophen, or in this case, we would consider maybe is there an issue of abuse of opiates? Is there a consultation that we need to get from the PCP or the pharmacist to make sure? And as a last resort, we can prescribe a third prescription of opiates, but let the patient know that this would be the last prescription. The opiates issued because without consultation of the patient's primary care or a dental pain specialist, this wouldn't really be recommended. So at this point, it would really be recommended to get a referral to manage the patient's acute pain. Alrighty, so the patient now returns for the fourth time after you prescribe, and now you're really, really confused because no one should be experiencing this level of pain. So, and you've done everything, you followed all the protocols. What do you do now? So at this point, you really should be referring the patient to their primary care or a dental pain specialist who has expertise in pain management. Avoid prescribing opiates any further at this point without consultations from the primary care or the pharmacist. You can prescribe a maximum dose of acetaminophen and NSAIDs until you get this interprofessional consultation. Alrighty, so I hope that explains everything for acute pain. So we'll be moving on to the management of chronic pain now. So we can start off with the definition of chronic pain, which is prolonged pain for about 3 to 6 months, I would say in duration, due to nociceptive pain, central pain, and sympathetically maintained pain, causing a chronic pain syndrome. Often it's accompanied by behavioral or psychosocial components. Okay, so if the pain is of the orofacial origin, the dentist can assume the role of the primary caregiver. If the pain is not primarily of the oral facial origin, collaboration with a medical specialist or a physician is suggested. Even if the pain is of the oral facial origin, you could still collaborate with a medical specialist. Uh, and it's usually recommended because the pharmacotherapy it's usually unfamiliar with the dentist. So acute pain, as we discussed, is usually resolved by targeting the cause of the pain. Chronic pain, however, is resolved by managing the, the symptoms. So, for example, if there's a patient that has temporomandibular disorder, um, so the TMJ caused by muscular or myofascial pain symptoms treated with is usually treated with physical therapy or cognitive or behavioral modalities. If the pair function is contributing to the pain, as you all know, an occlusal appliance is usually recommended. In severe cases of nocturnal parafunction causing intense myofascial pain, muscle relaxants can be prescribed, um, such as cyclobenzaprine. Usually, when these drugs are prescribed, it's recommended that it's not prescribed any more than 2 to 4 weeks. You can prescribe NSAIDs and acetaminophen, but you should never be prescribing benzodiazepines in these situations because these drugs have a high abuse potential. So TMJ could also be um, rooted from an intra-articular or degenerative or inflammatory origin. 1 second, I just need to get a sip of water. So if the pain is mild to moderate in these situations, acetaminophen is usually the drug of choice again, just like acute pain. And as I mentioned before, it has 4 grams of a maximum a day. Just have to be cautious about long-term use as it could result in hepatotoxicity, nephropathies, anemia, and thrombocytopenia. NSAIDs are usually a very good adjunct as an analgesic and anti-inflammatory. The risks of long-term use for NSAIDs, as we know, are gastrointestinal bleeding, cardiovascular thrombotic events, such as stroke and myocardial infarctions. Since the chronic pain from TMJ implies long-term use of drugs, opiates are rarely indicated, especially us as dental professionals. We shouldn't be prescribing opiates to manage the chronic pain for these patients. And it's something that the primary caregiver should be looking into. And if necessary, they would be prescribing it. Okay, so another example of chronic pain here is neuropathic or neuralgic pain. I know personally a lot of these, when I have a lot of these patients, sometimes it's really hard to diagnose and manage the pain for these patients because of their low threshold. So the first thing you have to do when you have a patient that you suspect has neuralgic pain is to rule out any central space occupying lesions. And this would usually be done by skull imaging, and also ruling out that it's not a systemic issue that's causing the pain. So consult with the primary care is usually recommended. And if you as a dentist don't feel experienced in prescribing the appropriate drugs, again, allow the primary care physician to become the principal prescriber here. Our job as dentists are to monitor the dental causes contributing to these disorders basically. So generally, pharmacological modalities are best to manage neuropathic pain. And let's see. And the drug of choice for managing neuropathic pain are usually anticonvulsants. Um, so carbamazepine, gabapentin, pregabalin, these are usually the drug of choice. Again, you just have to be very cautious of liver conditions before prescribing these drugs. And when prescribing these anticonvulsants, you usually have to start at a very low dose and increase until relief is accomplished. The drug shouldn't be stopped abruptly either because it starts giving the patient a lot of issues. So you have to usually wean off these drugs carefully. The best thing to do is to collaborate with a PCP for the pharmacotherapy here with anticonvulsants, as most dentists lack experience in prescribing these anticonvulsants. Again, like I said before, for the TMJ, opiates are rarely indicated for us to be prescribing here. Opiates are usually uh, for managing acute pain, for at least for our profession. For management of chronic pain that's not of the oral facial origin. So for these cases, the dentist is usually not the primary care provider. So this is in contrast to um, if it was originated from the oral facial complex, as I mentioned earlier. So what's important to know is the chronic pain can be compounded as a function of the psychosocial factors or trauma-related factors, physical factors, or even opiate abuse. So for these multifactorial reasons, it's usually best that the dentist is not the primary caregiver. Okay, so management of risk for opiate use. In some cases, opiates are necessary to prescribe. The problem is that it's overprescribed by dentists in excess of what's required. Some common reasons are due to habit or convenience of the dentist, patient demands, expectations, desire to avoid conflict, and inadequate patient history regarding substance abuse. So again, I mean, I also had, personally a lot of issues where a patient would come in and they would start demanding certain drugs, and it's very easy to fall into that trap and just to avoid the conflict and avoid creating a scene, just prescribe away the opiates. But we just have to be very mindful of these things. When opiates are prescribed in excess upon patient, the patient's adequate management of the pain, so you've already you feel like you've already managed the pain, the leftover pills usually have a very high potential for recreational drug use for the patient or for others that weren't prescribed the drug, so family or friends. This is why it's our responsibility to sufficiently manage the pain of the patient, but simultaneously also limit the potential of drug abuse. Especially if you think about it, there's a lot of these patients would have kids and a lot of teenagers who think these drugs are super cool and getting into the wrong hands. And um, it's our responsibility to make sure that we limit these things as much as we can. All right, so we'll move on to talking about assessing the risk. Before prescribing opiates, dentists must document the patient's pain level, uh, the medical status, and most importantly, a review of substance abuse. So one of the screening tools that the RCDSO recommends for substance abuse and misuse is the Cage Aid questionnaire. So I think I have it on the next slide here. So yeah, it's just 4 of these questions. And if the patient basically answers positive to 2 out of 4 of them, then you basically need to do a further evaluation and start questioning if opiates are the right type of analgesics you should be prescribing to this patient. So just to review the questions here, have you felt or ought to cut down on your drinking or drug use? Have people annoyed you by criticizing your drinking or drug use? Have you felt bad or guilty about drinking or drug use? Have you ever had a drink or used drugs first thing in the morning to steady your nerves or get rid of a hangover? Also, a part of our responsibility is to educate the patient before we prescribe opiates. So the patient should be advised to store opiates out of the reach of children. Um, you'd be surprised that a lot of times, a lot of patients would leave the pills in a very accessible part of the house. Never share the prescription as it's illegal and may cause harm to others. And the patient should be told that they should return any unused drugs to the pharmacy for safe disposal and prevention of diversion of the drugs to the streets. Detecting problematic opiate use. All right, so we as dentists must be alert of behaviors that suggest opiate use disorders. Some things we need to watch out for when prescribing opiates safely are as follows. So we have to be cautious if the patient is not well known to you. So in those instances, it's best to request 2 to 3 pieces of ID. Um, Another thing would be to screen the current and past uh, alcohol and drug use. For example, with the CAGE questionnaire. Next, is the patient suffering from opiate abuse? It becomes more likely if the patient requests a specific drug or states the alternatives are not effective for them, or say they start saying they're allergic to the acetaminophen that you want to prescribe. On top of that, if they keep insisting and they start refusing any um, confirmatory tests, so they refuse to get any x-rays done, um, and they claim that, say like you also prescribe some NSAIDs or acetaminophen, and they come back and they're like, oh, I lost the prescription, can you now give me some opiates? These are some problematic behaviors that we need to be mindful of. One other thing, I don't have it on the slide here, but there is the Controlled Drug and Substance Act that was imposed in 1996, and it states that a person who has received a prescription for a narcotic, such as an opiate, shall not seek or receive another prescription of narcotics from a different prescriber without telling that prescriber about every prescription or narcotic that he or she has obtained within the past 30 days. So that kind of gives a little bit of insight that there needs to be a lot of disclosure on the part of the patient, but also on the part of the dentist before we start prescribing these drugs. Okay, so you've noted that the patient that you have is experiencing a lot of pain, or so they claim to, and you've established that they're a high risk opiate user, maybe with the CAGE questionnaire and all your other screening tools, and you still want to prescribe this opiate to them. So, what are some things that you should be mindful of? So, the first thing is you should consult the primary care physician before prescribing. So the PCP can run a urine drug test to make sure that they're not currently using and abusing these drugs. You can look into doing a treatment agreement, and it's basically a written agreement between the practitioner and the patient that sets out terms regarding adherence to the therapy. So the agreement basically says that there's only one practitioner who will be prescribing the opiates and not multiple practitioners. It also states that the patient will use the drugs as directed and that the patient will use only a single pharmacy to get their drugs dispensed. And in cases where the patient doesn't have a primary care provider or primary care physician, a consult with the patient's pharmacist for a history of prescription drugs would probably also be recommended. So I was trained in the US, and I know we have a database there that before we prescribe any opiates, we were allowed to look up, and it's a massive database that really makes this process a lot easier. And unfortunately, I don't think in Canada we have a database for that. Dr. Hassan could maybe talk about it a little bit more later, but yeah, that's something that really helped. And maybe we'll have something like that in the future in Canada, where we could just look up the patient and see if they've had any history of drug abuse. Alrighty, so I think we're getting to the end here. All right, so this is the last slide. So when we're talking about pediatric management of pain, the best is to go with acetaminophen, and it's the drug of choice. I mentioned these numbers before, but here it is again. It's 10 to 15 milligrams per kilogram, a maximum dose of 65 milligrams per kilogram per day. Ibuprofen can also be used for 10 milligrams per kilogram every 6 to 8 hours. Usually there's two drugs that we absolutely really should avoid in children. And again, it's a little bit of common sense where, you don't prescribe aspirin. It could lead to Ray's syndrome in children, and codeine is also obviously contraindicated for children because it's due to the rapid metabolism of the drug and causes morphine overdose in children. Alrighty, so that I believe is the end of my presentation here. So thank you guys for listening, and I hope I was able to explain some of these topics to the best of my ability.
Thank you very much, Dr. Gazi, for this nice presentation. It is actually a very serious problem. First of all, can all of you hear me correctly, or maybe Dr. Sally can confirm with me by message?
Yeah, you're very clear. Dr. Hassan, Dr. Hussein also has a quick quiz for everybody,
sure,
just to refresh the information.
Oh, okay. So Dr. Hussein, why don't we do that? Why don't we do the quiz and we can have a little bit of discussion afterward?
Yeah, sure. Can we send the link for this?
Do you want me to send the link in the chat?
Sure, yeah.
Okay, I'll do that. Just give me a moment. Okay, so if everyone can go ahead and click on that link, you should be able to it's just some questions to refresh everything that you've just learned. You don't have to worry about being wrong, just answer it to the best of your ability, and then Dr. Hussein will review the responses.
Take this chance to quickly welcome our new associates, Dr. Rosemary Saati, Dr. Fatin Hikmat, both of them are soon to be doctors. Dr. Rosemary is a U of T graduate. Dr. Fatin is a University of Alberta graduate. I see Shada as well, welcome. I think Shada is a third-year dental student at the University of Western. Dr. Risha Sandhu, welcome aboard. Dr. Seema, welcome aboard. Dr. Abdullah El-Janabi, welcome. And who else? I just want to make sure I haven't forgotten anyone. That is all. Yeah, that's everyone. It's a pleasure to have you with us, and we look forward to more and more lectures, and maybe one day you will be presenting.
Hi, Dr. Gazi. First of all, Dr. Sally, thank you for the introduction. I do have a question. My question is, you mentioned that procedures that require bone removal, you would often expect more moderate to severe pain. And I was just expanding on that. Are there any other procedures where, you know, from the get-go, you would expect moderate to severe pain and go straight ahead to prescribing opioids without going through acetaminophen or an NSAID alone, other than bone removal? I mean, that's the one that they do mention is would cause kind of the most pain from a patient's perspective, but I was just wondering if there are any other procedures in your experience, or if any other dentists would also have their experiences to share where you would expect that level of pain that would warrant an opioid from the beginning.
Yeah, thanks for your question. So, like I said, the more research that comes out, it's showing that there's the way the mechanism of action NSAIDs have, and if you prescribe that together with acetaminophen, they tend to work nearly as good as opiates themselves. So, as dentists, our job is to prescribe these opiates are it's becoming less and less. But yeah, more specifically, obviously bone removal. If you're cutting a flap, if you have a patient that has fibromyalgia and you had to do a surgical extraction, multifactorial issues like that would warrant a prescription of opiates. Anything that really is was a traumatic extraction, or just a traumatic procedure in general, in those situations you could contemplate opiates. But like I said, I could probably count with one hand the number of times I prescribed opiates.
Thank you so much.
Thank you. First of all, thank you. Who actually asked the question?
Oh, sorry, I did not introduce myself.
This is Dr. Simon Najjar.
All right. Hi, Dr. Sima. Amazing. Very beautiful question coming out from you. I'm sure you're very well read. Thank you very much, Dr. Hussein, for the answer. Let me a little bit elaborate on this, and I'm sorry for the ding on my phone. Let's first of all tackle up the question that Dr. Sima has mentioned. I mean, we like to go with evidence-based answers, right? And I'm sure that wherever we remove bone in our general practice, mainly will be associated with wisdom teeth extractions. And if we're going to do that, we're going to cut the flap and remove the bone. Now, there has been a Cochrane study, which is, I'm sure some of you are familiar with it because I keep talking about it. And the authors are Espesetos and Paul Coulthard. And it says that the best evidence in pain management after wisdom teeth removal is a combination in the first 8 hours of 400 milligram of ibuprofen and 1,000 milligram of Tylenol. And after that, every 4 hours, either or, and there is no difference what you're going to prescribe. Most of the people do alternate. This is something to always keep in the head. Nevertheless, we should as well consider other things. Is there a role for preemptive analgesics? Should we give our patients something before we start? Is there an evidence base for this? Absolutely, there is an evidence base for this, is that we can definitely give our patients, if we are going to anticipate that this pain or this procedure is going to produce enough pain, we can definitely give them something before we start the procedure. But this something we're probably going to have to remind us of the way that our painkillers do work, especially if they're non-opioidal ones, if they are either NSAIDs or analgesics. and something that haven't been initiated. We all know that the pain is going to come from the process of ibuprofen, from the process of inflammation, excuse me. So that's why if we haven't even started anything, even though there is some studies that says that ibuprofen preemptively would work, there seems to be better evidence if you prescribe analgesics, meaning is that you can probably prescribe 1,000 milligrams of Tylenol about half an hour to an hour prior to the treatment. We as well, as I said, should understand what is pain, right? So when we are we're talking about pain, we always have to think that pain is a previous experience that the patient have had before, and he remembers it. So the way that people react to pain is going to be different from a person to a person. Yes, I am extremely in agreement with the fact that if the patient suffers, we should actually control his pain. But we should know what causes pain. Now, if the pain coming out from an inflammatory process, is the patient coming out from neurological reasons, musculoskeletal, which is still inflammatory, what is the best way? Is it an acute pain that we can just take the source out, treat the source, and the patient should be out of pain? Or is it a continuous type of chronic pain, like a muscle or a joint pain? These things as well need to be studied. So a better evaluation, and it goes up to the 3 elements, right? Always, 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 like history, examination, and special investigations. Take a proper history, you do a proper exam, and you can probably add to that a little bit of an examination, whether it was a radiograph or whether it was a blood work, even whatever it is, to find out what is the cause of pain. Now, we all have to remember as well, or remind ourselves, when it comes to the opioid prescribing, how is opioids metabolized? One thing that I probably would wanted Dr. Gazi to elaborate on is the metabolization of the drug. Which receptors does it work on? What the CYPs do they work on? The codeine, most of our drugs that we use in general practice, it just like gets metabolized with CYP 2D6, if I still remember things well. And as we all know, and this is where something that I've been confronted over my days of New York as well, we have to realize that there's about 18 to 20% of the population of the world are missing this enzyme. And if they are missing this enzyme, they're going to come to you. They probably would have extreme pain, right? And because the pain is very severe, they probably haven't shaven. And the bigger they are, the harder they fall. So they will look very big to you, scary. And they will tell you have an extreme amount of pain. And before they start, they will tell you, Tylenol number 3 doesn't work on me, doc. Are we going to deny them the treatment? And this is where the things are, because that question is one of the things that people always relate to. I was actually as well, for the sake of argument, I was very pleased to say that Dr. Gazi mentioned the CAGE. The CAGE questionnaire is something that brings good memories. It's something that we used to always evaluate patients for when it comes to alcohol abuse, but as well as being used to drugs. And I always remember the E's for the eye openers, just always laugh about it. It's like, do you really need a drink to wake up in the morning? And some people do, believe it or not. Same as well for the drug. So yeah, the CAGE questionnaire is a very simple way. I've sent us to the WhatsApp group as well. I don't know if you guys have had it or not, or you've received it or not. I have, send you a screenshot of the diagnostic criteria for substance dependence and addictions. Is that what are the things that you can notice if the patients have already an addiction? It is something as well for you to identify. And 3 of these actually will tell you if your person is. The truthfulness of the situation is that there is a lot of studies that are coming out that says patients don't use the narcotics because it cure their pain, but rather they're using it because either or they hear about it from other people, they're convinced subconsciously that it's the only cure, or unfortunately, they're dependent. Dependency is a chemical thing. You can be the best person in the world, but if you've got a back pain and you go to a medical doctor and he gives you 60 tablets, and guess what? You're hooked. And your body refuses to believe that it is. And there is actually an association between pain tolerance and an addiction. There is. So your pain tolerance becomes a little bit less. You're actually, whatever the things that might not hurt me too much will actually hurt a person who is addicted to the narcotics. So this is something that we need as well to bear in mind. A last thing that I probably want to share with everyone is that I know for a fact that there will be a study going to published very soon in the Journal of Oral Health, where a gentleman have looked at the fate. He used to prescribe after wisdom teeth extractions about 10 to 12 Percocets. And he looked, and after he finished up the extraction, he calls up the patients and he says, "How many have you used?" And I think he came up with an answer that about 80 to 90% of the patients only used about 7 out of the 12 that he prescribed. So there is really no reason. It goes up to the fact that we do understand what inflammation is, at the early stages is, and when is the pain going to be caused, and what causes the pain. So to link the pain with just a procedure, whether should we remove bone or whether, you know what, I totally agree with you. But you know what? There's even studies about fixing a fracture of the mandible that they said that you don't have to give narcotics. I mean, the trend is shifting towards avoiding opioids as much as we can, One last thing that I want to draw your attention to, and I hope that I'm not talking too much, is that we always have in the back of our head to associate certain things, right? If we're gonna give NSAIDs, long process of NSAIDs might not be a good thing for patients who is on other types of medications, maybe antihypertensives, or maybe I'm not saying about 2 to 3 days of it, but I'm talking about a longer time of it. Another thing that we probably need to know about is the impaired healing. We all know for a fact, in order for us to heal, we need a blood clot, and it doesn't help if we are going to give a COX. So COX stands for cyclooxygenase/thromboxane. So you're going to be definitely impairing the healing. Healing starts with an inflammation, as we all know. So this is something as well that we know, but we know for a fact that one of our good guys, and his name is Dr. Tamimi, he is the head of the dental research. He's actually Canada chair in bone, and he is the vice dean of research in McGill University, who have actually mentioned once to me, and I think he published an article that if you give NSAIDs at night, the actual mechanism of healing is not going to be impaired, which is quite a nice thing. I will forward the article up to the group. But all in all, thank you very much, Dr. Gazi, for tackling this such an important topic that we all think that it's very important, and it's definitely not being thought about it very much. One of the things that really irritates me is just like, are we just going to give 20 tablets? Well, you know what? Do we really need to give 20 tablets? So one thing that I really want you to know, that you are in a position of power. You have the ability to prescribe narcotics, and that is a privilege. Use it. Of course, your patients don't have to suffer. Use it. But when you use it with caution, not because afraid of anybody, because you're doing the right thing. Thank you again for all. And I'm open if anybody want to add anything or make a comment, and please put it on the chat, and I'll be more than happy to respond to it.